or can you?
Recording now.
Thank you. Okay, welcome everyone. I'm really delighted to have all of you with us. And what I'd like to do, since we are right on time, which is astounding to me, is I'm going to turn over our event to our speakers. Very quickly, Erica, do you mind just sharing the Zoom tip slide very briefly? We have recognize that this technology is pretty familiar to everyone on the phone at this point, but just want to do a quick reminder of what is helpful as you are in a meeting, and sometimes it's hard to interrupt. So as we mentioned, please click your mute icon, which is available to you generally on the left lower hand side of your screen when you are not speaking. As Erica has been reminding you, please display your full name so we can see who's actually at the meeting. Some phone numbers don't identify you fully. You can use the chat function to either communicate with us, with each other, to ask questions. We can put them in a parking lot for later on in the discussion. So please use it freely. We will be monitoring it all through the meeting. And if you do have, you wish to interrupt the presentation to ask a question or make a comment, you can do that by raising your hand in the participants list, and we will make sure that you get to ask your question. And you can click on lower hand when you're done. So with that, I'm going to maybe turn this over to our colleagues in Arkansas. And I'd like to take this moment to introduce my friend and colleague, Alicia Berkemeyer, who has been a true force of nature in working with the state of Arkansas on behalf of all the people that who live in her state and in the community. And really, I'm very proud to call her my friend and colleague. And Alicia, I'll let you introduce Claire and the rest of the team.
Thank you so much, Lisa, for that very, very kind introduction. And I feel like I've just got a bunch of friends and old colleagues on the phone that many of you have heard that me talk about the opportunities and the ways we wanted to evaluate these programs and show the success. Some of that being related to getting our self-funded accounts on board, but also just proving the benefits of these type of programs. It goes back to our CPC Classic. And with that CPC Classic, very impressed with the CMS Mathematica report and have always strived to kind of match up to that with the difference of difference. We had our actuarial team that matched that, but of course the actuarial is their priority. Matching up or doing a difference of difference study was a secondary job for them. The results looked very good, but again, when you provide your own data, your own internal evaluation sometimes with your customers, it's beneficial to have someone else on the outside look. So we had the fortunate opportunity to partner. We work closely with our medical school, the University of Arkansas Medical Sciences, the interprofessional education and other areas. We've contracted to have pharmacists and things of that such. So we reached out to our colleagues at the University of Arkansas, and Claire Brown is an incredible healthcare economist that we contracted with and brought her on staff working with us 20 hours a week to really evaluate and perform a difference of difference, not only on CPC, but on our PCMH as well as CPC Plus, which we're early into, but wanted to really look at, can we look at this at a difference of difference, and can we take it to a return on investment opportunity? We're excited about this reporting, and I won't take up any more time because I really want Claire to be able to share our good news with all of you, and just happy to be able to present this today. Take it away, Claire.
All right, can y'all hear me? Hopefully. Okay, good.
Yes.
Sorry for any, I'll apologize in advance for any awkward eye contact. I'm not used to have stuff on multiple screens, and I'm certainly not a good news reporter, and I don't know where to look. So, but hopefully you'll take away some good information from the presentation otherwise. But I do appreciate the opportunity to share these findings. So as Alicia described, there was an internal evaluation done by Arkansas Blue Cross and Blue Shield. Essentially what this internal evaluation found was an ROI of about a $2.4 to $1 return on investment. So essentially what this equated to was around $11 per member per month savings. This evaluation additionally found that there were greater savings in later years of these programs. Hopefully y'all can see my mouse, I'm not positive if you can, but you can look in the value for 2014 versus the value for 2017. These savings about doubled over time. And as Alicia described, they had done these analyses, but they recognized that having an external evaluation could be beneficial for a number of reasons, primarily just to have someone having dedicated time to do these analyses. Another potential challenge of this analysis is that these programs largely overlapped. So the CPC Classic and the CPC Plus don't directly overlap, but many of the clinics that participated in the Classic program also practice in the CPC Plus program, and also the Blue Cross Blue Shield PCMH program actually overlapped both of these programs, so they kind of created some complicated analyses. So for my analyses, I essentially evaluated each of these three programs separately. So I evaluated the CPC Classic, the PCMH, and the CPC Plus programs, each within these respective time periods that you see on this slide. Dark blue color is kind of what we call the pre-intervention time period, and the lighter blue color is kind of the post-intervention. So CPC Classic started in 2013, CPC Plus started in 2017, and PCMH for Arkansas Blue Cross Blue Shield primarily started in 2015. So one thing I want to point out is all of my analyses were at the quarter level. So any of the numbers you see with respect to my analyses for the remainder of my presentation are per member per quarter numbers rather than the Classic per member per month quarters. And this was just for some stability of our estimates and such. My analysis primarily included difference in difference analyses. So just as a quick overview of that, essentially what the difference in difference analysis does is it uses those clinics that did not participate in these programs to serve as a counterfactual for the clinics that did participate. So basically this lighter blue line is what we call the control group, and the trend for those control clinics is what's used to guess or estimate what would have happened in the participating clinics if they wouldn't have participated. So that counterfactual is what we use to compare to what actually happened, and that difference in those two values is called the difference in difference estimate. Where that name comes from is the first difference is the post-time period minus the pre-time period. The second difference is the participating clinics versus the non-participating clinics. So as far as our pre minus post time periods, as I described, the CPC Classic and CPC Plus have the start dates that align with the federal programs. However, for PCMH at Blue Cross Blue Shield, clinics could join these programs at different times. Therefore, their post-time period starts within the given year that particular clinic joined the program. So if a clinic joined in 2017, their post-time period would have started in this analysis in 2017. There's some pretty extensive inclusion and exclusion criteria that I applied in my evaluation. This was essentially because for this analysis, I really wanted to get at the efficacy of these programs. So this is, to mimic kind of as controlled of a setting as possible in this kind of evaluation. So to be included in the evaluation, a given clinic had to have at least 30 patients for in 1 year prior to the program and 1 year after the program initiation. And so what was called an eligible year is if that given year, if that clinic had at least 3 or 4 quarters of data in that year. In order to count for a quarter, the clinic had to have at least 30 attributed patients in that quarter. So again, this is all about having stability of estimates. For a beneficiary to be included in an analysis, the beneficiary had to be attributed to the same clinic and to the same program throughout the 3 months in that quarter, and that beneficiary had to have at least 3 quarters of data for a given year. Again, we're getting at efficacy and stability of our estimates. A couple of other inclusion and exclusion criteria. To be included in the CPC Classic analysis, a given beneficiary couldn't have flip-flop back and forth into the PCMH program. This was kind of to wash out some mixing of the programs that occurred for some beneficiaries. And for the PCMH program, a given clinic couldn't have been in either the CPC Classic or CPC Plus program because, again, these programs did overlap. Here at the bottom, you can see these are just counts of, oops, wrong screen. These are just counts of the number of clinics and beneficiary quarters that were in the analysis. You can see the CPC Classic had much fewer clinics than the CPC Plus and the PCMH program. My analyses included, again, these are all at the quarter level, the member quarter level, and all of the analyses included a quarterly time trend. It's well known that costs of care have increased over the entirety of the evaluation time period, so a quarterly time trend kind of can adjust for some of that. We also included a whole host of patient and clinic level and area level variables. So for example, patient level demographic information, gender, age, Alex Hauser comorbidities. We had a lot of clinic level variables such as the total number of patients that were within a given clinic, the number of primary care providers that had attributed patients, so this kind of simulates the amount of practice participation in some of these programs. Area level variables included access to care measures, so we have about a third of our hospitals that don't have, a third of our counties that don't have a hospital, for example. And we also controlled for various numbers of providers in the area and other factors such as those. In addition to the access to care variables, we additionally controlled for some area level demographics, so the racial breakup, the total population, percent urban and rural, things like that. All of our analyses did include standard errors clustered at the clinic level to control for correlation between beneficiaries in a given clinic. So this first slide here, this is the first slide of the results. This includes the findings with respect to the CPC Classic program. So the dotted line here is the initiation of the program. In this particular grid, I show here for the CPC Classic, I do have these for all the other programs after the conclusion question slide if for some reason we want to go back, but for sake of shortness of a presentation, I'm going to show these specifics for the CPC Classic. So the first difference in a difference in difference is the post minus the pre. So for example, in the control group, so the non-participating clinics, you can see that there was about a $145 difference in the post minus the pre. In the treatment group, or the clinics that were participating in the program, there was an increase of about $108. So the difference between these two values is what we call the difference in difference estimate, which was a little under $40 for participating clinics in the CPC Classic program. You can kind of see this as well as in this graphic, which we'll talk about later, but that essentially sorry, am I muted? Okay, the host muted me. I won't point any fingers, but I wasn't doing, I don't think. Can y'all hear me?
Oh, no, we can hear you just fine.
Okay.
There was quite
Okay,
a bit
good.
of background noise. So just to remind everyone, if you have to take a call, if you know it's a long meeting, please mute your phone when you're not speaking. Thanks.
Sorry, guys. I'll kind of start that sentence over, so sorry for any duplication. But as you can see over the time frame of the CPC Classic analysis, the light blue line starts to overcome that dark blue line. So that's kind of, in essence, the cost of care is increasing across the time period, but the cost of care is increasing at a slower rate for those participating clinics. So that dark blue line is increasing at a slower rate. So that's a good thing. That means that the total cost of care is less in the participating clinics. So here's the same three graphics for the PCMH and the CPC Plus program. One thing I want to point out down here, what I call the CPCE, I made this up, but Alicia liked it, so I stuck with it. It's the CPC Classic Extended Analysis. So essentially, these were the clinics that participated in the CPC Classic, not CPC Classic, the Comprehensive Primary Care Extended. So these are the clinics that participated in the CPC Classic that also participated in the CPC Plus. So it's essentially tracking their outcomes across both of the programs. So the treatment clinics in the CPC Extended Analysis were only those clinics that participated throughout both the programs. So if you can see here in the PCMH, pretty similar unadjusted difference in difference values, a little bit higher in the CPC Extended Analysis with a non-significant difference in the CPC Plus. It is a $5 increase, but it is non-significantly different in the unadjusted analyses. This is probably largely a result of two things, which we'll get into it some with the adjusted analysis, but first of all, the time period is relatively short. I only could look at 2 years after the initiation of the CPC Plus program, but also many of the clinics were already participating in the CPC Classic program, so they're unable to have as sharp of a change in their spending because some of those savings were already being accrued. These are the results from the adjusted analyses. These three rows here show per member per quarter, again, not per month, so don't get too excited. But These are per member per quarter, difference in difference estimates. So the top line here is the total beneficiary spending. So for the CPC Classic, the Arkansas Blue Cross Blue Shield PCMH program, and the CPC Extended program, you can see that there were a little over $30 per member per quarter savings in treatment relative to control clinics in the post to the pre time period. These are adjusting for all those things that I listed in the covariate slide. We looked at a couple different outcomes, but for the purposes of this presentation, because this is what's highlighted in a lot of the various reporting and mathematical reports, are the acute and ED visits. So these are total spending amounts for acute care visits. So you can see that these did decline for CPC Classic, CPC Plus, and the CPC Extended analysis by about $13, $7, and $16. And the spending towards ED visits also declined. For any of you who are familiar with or who do difference in difference works, difference in difference analyses, the superscript A represents regressions that didn't pass the parallel trends test. Essentially, all this means is that if the treatment and control groups are on different pathways or trajectories prior to an intervention, you have to be a little careful with the conclusions you make regarding those, because any difference you see could just be because they were on a different trajectory prior to the intervention. So that's anytime you see that little A, you want to be a little careful in that interpretation. These bottom two lines here show the probability change in having an acute care visit or an ED visit. So these two lines, the first two lines were the dollar amount. These bottom two lines are the probability. So numbers here represent a percentage point difference. So you do see that we had significant declines in the probability of having any acute visit in the CPC Classic, CPC Plus, and CPC Extended evaluations with respect to acute care visits and ED visits. This is a pretty, 1.4 percentage point decline's a pretty good decline. The average percent of visits were, I think it was around 5% per quarter. So that's a pretty big relative decline. Those are absolute differences because they're percentage point differences. So the big takeaway, though, is what we saw when we looked at the findings over time. So if you remember back to the CPC Classic time, the trend lines, you saw that the light blue line started to overcome that dark blue line more so in the later years. So that's exactly what you can see here with respect to the difference in difference analyses across the program years. So these are the program, each of the program years in the post time period for the CPC Classic, PCMH, and CPC Plus programs, and you can see that the savings per member per quarter grow over time for all of these programs. On this slide are the return on investment. So essentially these are taking the difference in difference estimates for a given year and putting those in terms of the care management fees that were paid out for beneficiaries, the average per member per quarter care management fees. So because the savings are growing over time and the average care management fees are relatively the same per member over time, the return on investment similarly grow over time. The royal blue here at the bottom are the overall return on investments for each of the programs. So about 2.5 to 1, 2.2 to 1, and as we talked about before, the CPC Plus didn't have as large returns on investment yet. And here are those same numbers, but for what I call the CPC Extended analysis. So here you see that these savings do grow over time with respect to the difference in difference estimates, which are here on the left-hand side, and with respect to the ROIs, which those give you an estimate of the estimated savings per dollar invested in the program, which are captured in this case by the care management fees. And that's all that I have, but I'll be happy to take questions whenever we're supposed to take questions.
Claire, thank you so much. That was a really exciting presentation, and it's just wonderful to have you join us today. Are there any questions immediately before we move on to our next presentation?
Lisa, this is Alicia. I would just like to add, I think we're all very excited. We've all talked about the longer these practices are in the program, the better outcomes that we are certainly seeing. That shows the hard work that the practices have to do in those first couple years, that the investment and the changes and the transformation, it takes a while. And for this to be shown and to do, Claire's very right when she told me that I love to see the CPC extended. And when she brought that to me, I was like, yes, that's exactly. So that just shows what we all know and have believed. And we were happy to be able to show the proof points of the longer these practices work, we see greater improvements. So thank you for allowing us to present this information today. And we're pretty excited and look forward to continuing to measure it and monitor it.
Absolutely. Thanks, Alicia.
Oh, Lisa, this is Craig. Just one quick question for Claire, if it's okay.
Sure, go ahead.
Claire, I was wondering if you had a chance to look at the distribution on the results and you have a sense for maybe what proportion of practices fall into a gain versus those that had a different outcome, whether the distribution varied by any particular factor, whether it was geography or type of practice. Just wondering if you had a chance to look at variation yet. By the way, very impressive analysis. Thank you.
I appreciate the kind comments. I haven't looked at that specifically. I know that I have been given the opportunity to continue my work with Blue Cross, and hopefully that's something I'll be able to look into. This is a particular project that I was contracted out to do, and so I hope to be able to continue these analyses, and that's certainly something we want to look into. You know, in Arkansas, we, for example, have some areas of the state that have very different access to healthcare resources, that we have some very rural populations. I'm particularly interested in racial and ethnic health disparities. I'm hoping to be able to dig into this some to look into those kinds of things. I certainly think that it's highly likely that some populations were more likely to benefit than others, and that some clinics saw greater gains. But we haven't, I haven't looked into that. I'm not sure if anyone else from Alicia's or the actuarial team has been able to look at that.
Yeah, thanks, Claire. We have not had a chance to look at that yet. As Claire mentioned, we're in the process of recontracting, so we can continue this work with Claire and really dig into one of our interests, Craig, we've been wanting to see is how do we use this data to reshape our programs, and how do we improve our programs? What brought to us this difference and these changes, and how do we better design in the future? So we're in the process of getting that work. Claire actually is a professor at the university and teaches on a, you know, pretty much full time there at the university, and we're fortunate to be able to get her time and looking forward to the continued exploration.
This is Diane from Michigan. Just one really impressive work. Thank you so much for sharing it, Alicia. Just one question on your observations about CPC Plus and that cohort specifically. Do you perceive that part of that is the limited number of years that you were able to analyze CPC Plus, given that it's still in play? And I don't know if you've done any regression or additional predictive analysis to see what you might see happening by the end.
Yeah, Diane, you're exactly right. We being early into CPC Plus, even though many of the practices had been in CPC Classic, we feel like just kind of the start and the time frame of the data is short. We'll continue to monitor it, but we've not done any predictive yet. So Claire, I don't know if you want to add anything to that.
Oh no, I agree with you completely. I mean, I think it's based on the other programs, you know, when we actually saw slight increases in the first year, it's almost promising that we didn't see those significant increases in the CPC Plus program like we did see in some of the other programs. But I do still think that part of it could be that many of the programs that are participating in the CPC Plus, as we mentioned, already practice in the CPC Classic. I think that the relative gain may be, maybe in a different, it may be a different type of gain or a different type of savings. I think it could potentially be in different places, and that's something I hope to look into to see if, if we do capture savings in the CPC Plus program, to see if those savings are different for clinics that already participated or who are in the CPC Classic versus those clinics who are new to the CPC Plus program, because I think that there's a lot of economies of scale and scope and different things that we can look into to kind of see. And I think also another thing we can look into is here in Arkansas, we have some very large clinics and some not so very large clinics, and to try to see like how that could influence the savings for a given clinic.
Thank you.
Okay, so this is Lisa. I'm going to move us along on our agenda. I do want to make an important point, which is that this type of research is really something that we have a tremendous interest in, and I think if there's we are all in this process together, and the more we learn from the experience of the people who've been involved with this at the local level, the more we can tailor this program so that it continues to benefit the patients who go to the practices that are benefiting from the support that the payers are putting into it. So one of the things that I also did want to mention is that this piece that you just heard about from Claire and Alicia, along with information that you'll be hearing in just a moment from the team in Oregon, are both going to be published on the Milbank Memorial Fund website this summer. We're delighted to have incredibly well crafted research and manuscripts that we will be putting out into the public domain. We think that will enhance the discussion moving forward, as obviously there are policy decisions that need to be made about how to further support primary care. So thanks for everyone for being part of this and for the support during this work. And you will be getting lots of notices from us that we will be putting this information out to the public on our website, and hope to get it picked up in other venues as well. So with that, I'd like to turn our attention over to our colleagues from Oregon. As I mentioned, the people who will be presenting are leaders of the Oregon Comprehensive Primary Care Plus Payer Group, have been facilitating a large, very large group of individual payers for years now, which is just such an impressive thing to me. And what we're going to be hearing about is how they pulled this group together to create a very informative and dynamic learning tool to be able to understand the impact of the interventions on how patients in Oregon are doing, both in terms of quality and in terms of outcomes related to cost and utilization. So with that, I'd like to turn this over to our colleagues from Comagine Health, Lisa Miller and Emily Seitz, and Diana Bianco, who represents Artemis Consulting, the team from Oregon.
Thanks so much, Lisa. This is Diana, and I'm going to just do a brief introduction. Emily and Lisa are going to walk us through the bulk of the presentation. It's telling today that most of the agenda is focused on assessment and evaluation, and that's not surprising given that we're several years into the conversation. And as we just heard from Arkansas, these are really valuable conversations and really important. The Oregon CPC Plus Payer Group has been meeting since 2017, and Lisa sort of mentioned, wow, this is amazing that the co-conveners have done it. I'd actually say it's a testament to the commitment of the payers. It's been lots of work and hard work, and the payers have continued to show up. We have 10 payers right now. We started with 14. A few of our payers left the program, but the group, when they started in 2017, really has been focused on alignment, sharing information, lessons learned, and increasingly ROI. And what are we learning? We've been asking questions from the start, and really with our data aggregation solution have been starting to answer some of those questions around what are we learning about the payment model? Is it making a difference in terms of how care is delivered? What kind of difference are we seeing on quality, on utilization, on cost? We all want to know how it's making a difference for patients. And none of us have all the answers right now, but we've started down the road, and that's what you're going to hear about from Emily and Lisa. And we do data aggregation with Comagine Health, who is also one of the co-conveners, but this is really a separate piece of work. And to get to a data aggregation agreement amongst the payers, it was about an 8-month process. And it was a lot of conversations. We had a series of principles and a framework that included that acknowledgement that all payers were in different places in terms of collecting data, that we required payer commitment and leadership for over the long haul, that it was important that we had as many payers as possible participating. We also acknowledged the challenges, but also the opportunities. And finally, we knew that any data aggregation solution had to support the kind of assessment and evaluation we wanted, because the payers and all of us really wanted Oregon-specific information to help the state understand how this kind of value-based payment impacts primary care, and thinking about the potential for spread beyond participating payers and providers. So I'm going to turn it over to Emily, and I know we also have a couple of Oregon payers on the call, and at the end of the presentation, if they're still on, I'm going to ask them to chime in a little bit to give their perspective. But with that, I'd like to turn it over to Emily.
Thanks, Diana. Oh, let's see if I can advance these slides. There we go. So we often joke that at Comagine Health, we have to wear two hats in CPC Plus. We have our convening hat and our data aggregation hat. So I'm putting on my data aggregator hat for a second here to just give you all a little bit of background on our voluntary all-payer claims database here in Oregon, which we call the Oregon Data Collaborative. Our voluntary APCD has been in existence since about 2009 and includes payers, the majority of the payers in the CPC Plus program, but also non-participating payers. We have primarily used that claims database to do cost, quality, and utilization reporting to primary care practices in the state, and that effort existed prior to CPC Plus, but was enhanced when CMS joined as a partner in data aggregation in 2018 as part of CPC Plus. And wow, a typo on the acronym APCD. Craig Jones, don't tell on me. So through, like Diana mentioned, kind of through conversations with the payer group, there's always been this interest and emphasis on analysis of the CPC Plus program. And the group's interests were really sparked after seeing some of the early results from the Mathematica evaluations, but acknowledging that that was just on the Medicare fee-for-service population and didn't really address the interests of the payer group and their populations. We were really inspired and excited by the work that the Ohio group did out of the Health Collaborative and some of their initial analyses that they produced back in 2018, 2019. And the group kind of had this acknowledgement that, wait, we could be doing something like that here in Oregon. We have this multi-payer claims database that the majority of the payers are contributing to. It's certainly not a perfect tool for evaluation, but it is a great place to start for analyses and to start to generate and answer some of these questions. We also had some unspent money from the dollars we collected to support our convening efforts, so it felt like a natural place to go with that unspent money was to invest in these data bites. And so we embarked on establishing the first 2 data bites, which Lisa will go through a little bit more in depth in a moment. But wanted to really just focus on starting to examine this program and get the information out to our stakeholders, as folks did. So I'll turn it over to Lisa to talk about the results. I will also drop in the chat a link to where the data bites live in their entirety on a website that includes both the data bites as well as the full methodology and results for each of them. So if you feel like exploring more, you'll be able to do so there. And Lisa, I'll send it over to you.
Thanks very much. I'll outline a little bit of the methodology before beginning, just so it's so we're clear what we're talking about. We compared practices that participated in both CPC Classic and CPC Plus. We conducted this analysis using data from 2017, so it was only the first year of CPC Plus. Also, it's a snapshot in time, so we were looking only at performance in the year 2017. We do have plans to do some trending over time analyses coming up next. But what we're looking at here is 2017 participating practices versus non-participating practices, or the comparison practices. And similar to Claire's analysis, we eliminated those practices with fewer than 30 patients in the denominator. We set statistical significance at 0.05 on our analysis. So getting into the results now. Our first data bite looked at quality of care being delivered in the practices. And we found that practices participating in both CPC Plus and Classic had a higher performance rate than the comparison practices across all payer types. Then, sorry, I said then the comparison groups, on both breast cancer screening and on cervical cancer screening, actually on a lot of measures, but these are the first 2 that we wanted to illustrate. So you can see the results there The leftmost column in each chart is all payers, and then broken down by commercial, Medicaid, and Medicare. On those, you can see the asterisk after the number indicates which ones were statistically significant. So in breast cancer screening, it was significant across every payer and across all payers and commercial in the cervical cancer screening. Next slide. Thanks. Our next data bite took a look at utilization and cost of the care being delivered in these practices. We found that participating practices had lower adult ED utilization and fewer avoidable ED visits when compared to the other non-participating practices. There was some difference between the payers in terms of significance. You can see, for example, on the left chart there, ED visits per 1,000 member years was significant in all payers, actually was significant in every individual payer as well. On the avoidable ED visits, though, it was significant across all payers and then Medicare fee-for-service, not necessarily on the others. Next slide. The second data bite also looked closely at cost. So there's a lot of caveats on this one. Being claims-based, of course, it doesn't allow for alternative payment methodologies. To address that concern, we included only claims-based facility costs. The professional services and alternative payment methodologies, therefore, are not reflected in this analysis. Similar, what am I trying to say? Statistical requirements as the others with the 30 patients per practice, et cetera. So participation in both CPC programs was found to be associated with lower risk-adjusted costs of care than the comparison group in the commercially insured patients. We actually only have claims-based cost available for our commercial payers and for Medicare fee-for-service. And for other reasons, contractual reasons, we were not allowed to do this analysis with our Medicare fee-for-service data that we received from the qualified entity program. So we were only able to conduct the cost analysis on our commercial payers, data, I should say. So we found statistically significant differences between the participating practices and the comparison group across emergency services, inpatient, and outpatient. Next slide. So our plans for what's next include doing several more of these. Like I mentioned, we definitely want to look at trending over time. So we are going to go back and look at the analyses that we looked at here on primary care costs, quality, and utilization, and trend those over time. So we're going to go back further into CPC Classic, and we'll have 2 more years of data of CPC Plus to include as well, so 18 and 19. We intend to look at the some more emergency department measures, so quality of utilization care, quality of emergency department care, and some utilization numbers again there. We'll look at inpatient utilization, care coordination and transitions of care, and then look carefully at specialty care as well. So in each of these, we're figuring out exactly what research questions we want to take a look at, but the CPC Plus payer group was really rewarded to see the statistically significant results on these 2 data bites, and is interested in having some more analysis done going forward. So they've committed to purchasing 5 more data bites over the next year. CMS also is very interested in the findings from these first 2 data bites, and we're in discussions with them about the possibility of their purchasing some additional data bites as well, or commissioning some additional data bites. So within these topic areas that are listed on the slide here, there are obviously many research questions that could be asked. So that's where we're going to be pulling the data bite ideas from. Diana.
Yeah, let me just, oops, thanks Lisa so much. Are you guys hearing feedback, or is that just me?
No feedback, but let me mute.
Okay, how about, okay. So let me just say a couple more things, and then I actually am going to invite Krista Mars and Krista Shively, and I'll see if we have any other of our participating payers on the call to chime in. But here's So we just gave you a sample of what those data bites are. And in fact, on the quality, all of the measures that we looked at the quality, on the quality data bite showed that CPC participating practices performed better across all payer types than non-participating practices on 24 out of 26 measures that we looked at. So we looked at a lot more measures than what you saw, but Lisa really highlighted some of the, gave us some of the highlights. And that's really important. And again, we can't claim causation, but we can sort of look at correlation. And that's similar on the second data bite, which addressed utilization and cost. That we really did see some important differences. And then the last thing I'll say in this moment is that these are data bites, right? Meant to be little bites of information. And we were really looking for, and Comagin did a great job with this, sort of what was easily digestible information that we could share back with payers as well as the larger community in Oregon about this work that the work that many providers and payers have been doing for a long time. And what was sort of an easily digestible way to start getting at that. And so I think this is the beginning of that conversation, and we hope to continue it. So I'm gonna ask, why don't I start with Chris Mars. Chris, if you would just chime in from a payer perspective, and then if Krista's still on, we'd love to hear from her too.
Yeah, sure. So these data bites were incredibly useful with leadership at the Oregon Health Authority to have them kind of understand the value of the program. The conveners, and I think it was maybe just Diana, set up a meeting with each of the payers, and for OHA, it was myself and another colleague, and then a few folks in OHA leadership. And when we got to the data bites and the kind of the bottom line there around return on investment, their eyes lit up, and they kind of got the value of the program in a way that they, over the last few years, I don't think it had really resonated for them, and they've used the data bites and conversations they've had, and so I would just say that this has been a really important investment for the payer group to make, and I'm really excited to see what other data whether other results we find in the future data bites.
Thanks, Chris. Krista, would you chime in on your perspective from Providence?
Yeah, so I agree with everything that Chris noted, that leaders really light up when you start seeing results. I think there were a couple of factors in Oregon that really contributed to us being able to do this. So one is that with our CPC Plus convening, we have a partnership with the Oregon Health Leadership Council. And at that forum, which is a multi-stakeholder forum, they're consistently asking, well, what's happening? What are you seeing? What are the results? And I think that was an infrastructure that hadn't existed prior, and it was a good kind of accountability that's, not just at an individual organizational level, but really more at a community level. So I think that was super helpful in really pressuring, in a good way, like healthy pressure, for the payer group to be demonstrating what we're seeing beyond the evaluation that CMS is doing, which is really only on that fee-for-service population. I think it also helped buttress efforts among other payers to be doing their own internal evaluations. So a lot of these measures that you see in the reports are common measures. These are, the frequently asked utilization and quality measures. And it allows for other payers to segment it. And for us, we have been consistently segmenting along some of these similar measures, but we actually weren't seeing a delta. And so it was really kind of calling the question for us, like, why are we continuing to participate? It's actually helpful to see at a community level that we're part of something bigger that is demonstrating a delta, because part of our mission is being our community's health partner. So even if we're not seeing it within our slice of the network, the fact that the state is seeing it, that the community is seeing it, is still part of our mission. And so I think that was a really important message and point of evidence for us to demonstrate. I think it was also just incredibly fortuitous that we had leftover facilitation dollars that we could say, what's the best way to spend these dollars? I think we had talked about evaluations in the past at an earlier point of time, and just didn't have the data, and so that hadn't gone anywhere, because if you don't have the data, there's nothing to do. And so the timing was just right. We finally had enough data and experience that the practices, to Alicia Birkmeyer's point about practices just need time to kind of go through the disruptive part of transformation and start where you can actually start seeing some of the performance evolutions. So we had the benefit of that, and then the benefit of a funding source, all kind of converging at once at the same time. So I think I'm really excited to see where this takes us next. And we have a ton of great ideas, more ideas than we have funding for kind of other bites that we want to do in the future. And so this will be part of our ongoing work in 2020 and 2021.
Great. Thank you so much, Krista.
Could I add one other thing, Diana,
Absolutely.
that as Chris was talking, it made me remember another use of the database. I think, so from OHA's perspective, I think having that data has kind of launched a conversation around value-based payment and spreading value-based payment more broadly than the CPC Plus program and then primary care. And I think just having, I mean, there's a dearth of data out there around value-based payment. And so I think any kind of anything like this can really help to launch conversations that go beyond just this program, and that it has done that for us at the Oregon Health Authority. So I'm really grateful for it.
Great, thanks, Chris. Let me see if there's, Lisa, I'm going to turn it back over to you in terms of taking questions. We're happy to take questions. I know folks might have questions for Arkansas as well.
Okay, thank you. And thanks to all of you for a really fabulous presentation. I'm always really in awe of the ability of our colleagues, all of you included, to be able to share complex information in such a way that we can consume it. So thank you. I wanted to make sure there were a couple of questions that came in on the chat that I wanted to make sure that got answered. First one came from Dr. Shank in Ohio, and specifically I think that was for the Arkansas group, which was asking about the volume of practices that were included in the analysis. So I don't know if Claire or Alicia, you want to answer that quickly.
Do you mean the number of practices or the number of patients within a given practice?
That is a question I don't have the answer to, actually. Dick, did you want to clarify that?
Yeah, we follow it based on number of practices that are participating in our market, and I just, either way, just to get a feel for, I was just actually typing in another question, which is, what we're dealing with the Arkansas data, it's one payer data, if I've got it right, and in the
Correct.
Oregon data, we're talking about a multi-payer view. Is that accurate?
That is.
Correct.
Okay.
On our
So
end.
I was just trying to get a feel for the volume of data that you were dealing with, and how many practices that affected, and I know it could be the number of physicians in those practices, but just a feel for the amount of data that you were dealing with in the Arkansas group.
So the number of clinics that were included in my analysis, for the CPC Classic, it was 47 clinics. For the
Okay.
CPC Plus, it was 112. And for the PCMH, it was 114. Now, this is a little lower than the actual number of clinics that are involved in the programs for a couple of reasons, primarily, maintaining in the program and then the number of beneficiaries. But Alicia may have more, I think it's more like 60 that were in CPC Classic, and more like 120 or so that was in CPC Plus, or maybe a little more than that.
You're right.
So you excluded some based on volume, and not some practices didn't have the 30, I think it was, and so forth. So the numbers you're quoting are the ones that were included in your study.
Yes, sir. Those specific numbers were, and there were a couple practices, for example, that got bought out, by another practice. So those kinds of things kind of can add one or two on either side, but
it's very helpful.
Okay, thank you. So I do want to just underscore that observation that Dick just had, which is that one of the reasons I wanted to showcase both of these evaluations or assessments was that it is the contrast between looking at a single payer's experience, broad as it is, but nonetheless one payer in a region, and then in Oregon's case, looking at a multi-payer process, which is different. And just as so you know, the breakout sessions were also designed that way because obviously there will be interest in both areas. So I hope those will be excellent sessions as we walk through this. I'm going to read off a couple more questions. Chris Kohler, our president of the fund, had a question that looks like it's sort of getting discussed on the sides here, but thinking about what, for anyone to think about answering this, what would it take for market-specific results like Arkansas's to have an impact on payers and purchasers in the market? So in other words, what kind of an impact do you have on other participating or not participating payers to pay attention to this? And obviously in the context of what COVID has done to our general welfare, especially around primary care, you know, what kind of impact that would have. I don't know, Krista, if you wanted to elaborate on your question a little bit.
Just given the time we have, people can feel free to add in the chat. And why don't you move on to other questions and I'll just see the response.
Great.
Thank you.
Okay, thanks. So from Dan Vizzini, had a specific questions for both evaluations. Is there any risk adjustment that's taken into consideration when you're looking at the patient population? So either by provider or by practice.
So in our analysis, we adjusted for, the primary thing we adjusted for was Elix-Hauser comorbidities. And that's about as close. I mean, there are, the actuarial team does have some prospective and retrospective risk numbers that they have in the insurance claims, but the way that these were calculated changed because we were looking at, you know, several years of data. So I didn't want to use those exact risk scores across the entire time period. They would be appropriate to use within a given year, but without using a yearly time trend, it may would a fixed effect. It would probably be inappropriate to include that. So I use comorbidity measures.
And we use the Johns Hopkins ACG risk scoring methodology. So we applied that to our cost analysis and not surprisingly found that the risk score was higher among participating practices. It was 1.06 compared to the non-participating practices of 0.96. So that's accounted for in the results.
Thank you, Lisa. So a question that I think may have already been partially answered from Bruce Wall, Aetna. Did Blue Cross Blue Shield of Arkansas have value-based programs in addition to those studied in play during its evaluation period? So you mentioned the PCMH program. I guess the question is if there were other value-based programs in addition to that during the study period.
Alicia, you may have to answer that one. I mean, those are the primary care value-based programs.
Yeah, that certainly, like I said, Claire points out there, we were focused on the primary care for those 3 programs, and we have some episodes of care and some ACO work that's done separately. And as Claire mentioned earlier, we're in the process of recontracting and realigning the scope of work in some areas. So those will, especially our ACO work, we're wanting to kind of align with some of this as well. So, but the focus has been on CPC and digging into more of the CPC PCMH success.
Thank you, Alicia. Question from Dr. Haft in Baltimore. Did the Oregon program look at any clinical measures, clinical quality measures that could have been gotten from the electronic medical records and practices?
We did not. That's something we would love to be able to do, but up to this point, we only had access to the claims, and that was what we analyzed. That's definitely a goal for the future.
That's different for us, and we actually are in the process. I know Ann and Dr. Golden are on the line, but with Ann's leadership under our health information exchange, we are in a discussion with multi-payer group to see if we can pull some clinical measures in through our health information exchange across all payers around CPC, PCMH efforts.
That's very exciting.
This is Diana. I'll just chime in from Oregon too. All of this was part of our 8-month process about here we have, we're going to get claims data. When can we get clinical data? And there is some work at the state with a clinical quality metrics registry that could help down the line with this. But there is this ongoing, we all know sort of the holy grail would be clinical and claims data. And that's something, as Lisa says, Lisa Miller says, that's something that we've thought about, you know, how could we make that happen in the future? So really appreciate the question.
Okay, I'm going to put out another question that came in on the chat. So the question is around differentiating the pool of providers that are actually not participating in the CPC Plus. So I'm just going to read this off. This is from Dan. So looking at the multi-payer analysis, does it make sense to differentiate non-CPC practices by those that are participating in enterprise-based quality improvement initiatives and those that are not doing any kind of transformation initiative? So further trying to differentiate between the practices that are not part of CPC.
Yeah, that's an interesting question, and that would be a really rewarding analysis to take a look at. We really only have claims, so we don't have the information available without working with other partners to know what other transformation programs might be going on. We do have a statewide patient-centered medical home program that's going on, and there's been some evaluations of that. So we know there's other work going on to transform primary care in the state. So it would be really interesting to try to differentiate between those programs and any others that are underway.
This is Dan. Just to follow up, the thought that popped into my mind there had to do with the ROI that you'd calculate for comparing CPC plus practices with practices that are doing nothing at all might be much more significant than, because that non-CPC plus population may include practices that are in ACOs or doing initiatives that are driven by payers themselves. So it's the real extremes. Who's doing transformation work through a program like CPC plus versus practices that are not doing anything at all. That was the thought.
Thanks, Dan. Any other questions or comments from our colleagues? Okay, well, I think everybody should turn their audio on and let's applaud our speakers. It was really excellent. Thank you very much. So we're pretending to be together. It's really, it's an honor to listen to this work, and as I said, I'm really in awe of it. So I want to thank everyone who took the time to both participate today, and especially to our presenters for doing the great work and sharing it with us. One question that did come in on the chat was whether the slides would be available, and we will make sure that some version of the slides will be available to everyone who's on this seminar today, as well as to your colleagues. So with that, we're just a couple minutes ahead of schedule, but I think I'll take this opportunity to ask everyone to take a quick bio break. Please do not disconnect yourself from the meeting, or else we will have trouble putting you into the breakout sessions. And what I'd like you to do is just step away from your computer for a moment and come back within the next 10 to 12 minutes. And at that point, we will go right into our breakout sessions. Thanks, everybody. See you in a few. It's a glitch we didn't expect, but we'll figure out how to fix it in the future. So moving on, it sounds like all the sessions went pretty well, and what I'd like to do is turn it over for the next just few moments to the facilitators of each session to give us just a 2 to 3 minute high-level overview of what was discussed. So Erica, I'm going to start with you.
Sure. So we were talking about evaluations at the regional level and the utility of those, the sort of drivers for those, as well as who the audiences might be and how they varied. We also talked a little bit about the various dimensions of measurement and their relative importance to different stakeholders. So we talked a little bit about regions that have multiple payers, and I can speak to at least in Philadelphia, where we don't have an all-payer claims database or a voluntary all-payer claims database. So it presents some challenge to doing the analysis that was done in the Oregon data bites, but not insurmountable. And we're exploring a couple of different ways to do that through pooling of specific data rather than trying to aggregate all data. We also heard from from folks in single payer regions or regions where there is a big difference between the engagement of some payers and others, and then how that presents its own challenges. We talked a little bit about state payers as payers or states as payers, and the fact that they don't necessarily have the same stakeholders and audience that commercial payers do, which are primarily employers and self-funded entities. But states nonetheless have constituents, and they have budgets they have to manage to, and certainly COVID has stretched many of those thin, and there are continuing questions of wanting to see the ROI, as there always have, but perhaps even more so now with the tightening of those budgets. We also heard from some folks thinking about evaluation and wondering whether the standard evaluation of looking at healthcare expenditures, which are essentially expenses as opposed to looking at ROI from a revenue standpoint, whether those are the right measures, and whether we are measuring what the practices have a realistic ability to control or to impact. One thing that I thought of, I didn't get a chance to add in our discussion, is that one thought we've been thinking about here at Discern Health is looking at leveraging some tools like the Milliman MedInsight Health Waste Calculator, or Clarent also has a tool that looks at basically low value care, no value care, and essentially waste, as well as over and under utilization. And here's my cat likes the top of my chest. All right. But anyway, that may get closer to what we were trying to get at with the measurement there about let's look at, rather than just total spending, because maybe some of that high cost care was important and critical and can't be adequately adjusted for or carved out. But maybe we should look instead at where is that low value care or that wasteful spending, and our practices having an impact on that. That is something in many cases they can have an impact on. The price of a given service, the price of an ER visit, the price of a procedure, most primary care practices will have no influence on that. So you can only really measure them on utilization as it relates to whether you could steer a patient to a lower cost setting or to an alternative treatment that perhaps is less expensive. And then we just talked a little bit at the end about the role of HIEs and how the master patient index or master person index has the ability to sort of connect the longitudinal history of claims and utilization of patients across payers, also across geographies, of course, and across settings, and how that presents its own possibility for evaluation and looking even longer term than just a couple of years, and perhaps over much longer periods of time where patients have floated between payers, especially payers like Medicaid, and going in and out of commercial insurance for those who are temporary or gig economy type workers. So that's kind of the summary of what we covered. Lisa, did I miss anything?
I don't think so. Thank you, Eric. It's great. Turn to Diana and Emily.
Sure. I think we had some similar conversations to Eric, kind of dancing around similar topics. The first thing we really talked about is the challenges of doing collaborative assessments are kind of around, there's so many value-based payment programs going on in a given state. So how do we accurately, how do we pick our groups that we're looking at in these assessments? What's that impact on provider organizations constantly to address all of these different requirements that come along with these different value-based payment programs? And talked a little bit about the importance of measure alignment or just multi-payer alignment in these value-based payment models and that's impact on assessment. So, how can we reasonably pick some measures to evaluate these practices on if each payer is requiring 30 different measures? Hard to measure collective impact in that environment. And we heard a little bit from Dr. Shank about Ohio and their approach to a more refined or shorter measure set for their participating practices. We also talked about the impact of COVID-19 and value-based payment on primary care. And I really loved Julie. I got a quote from Julie that I'm going to use forever now, which is, "Don't let a crisis go to waste." So how do we see the impact of COVID-19 on primary care practices and the acceleration of value-based payment within our regions, and then the kind of ripple effect and impact on assessment going forward? We also talked about some of the different audiences for these assessments, and Eric touched on this a little bit, but kind of the role that large employer groups might play in being interested in the outcomes of these assessments, or really interested in the results of them, and how can they help support and enforce that messaging to their employees that they're hearing from their primary care practices, and where there's maybe more opportunity for engagement and alignment with payers and employers around those topics. We also discussed some of the barriers to doing collective and collaborative assessments, and I think maybe the three that came to the surface are the three we've all heard, which is getting the data, the cost of doing the work, and kind of the settling on a study design or analysis approach that everyone can agree upon, especially in a multi-stakeholder environment. Diana, what did I miss?
Oh, that was great summary, Emily. Thank you so much.
What's the secret?
I was hoping you'd tell us.
I certainly don't know, but that's great. Thank you. So it sounds like that was a great discussion. And then Craig, I think you're still on, so maybe we can have you just give a quick overview of what your group was discussing.
Sure. We were talking about data aggregation and working toward a number of different items, hopefully to give some input into the priorities for the future, and maybe how to improve the impact and the effectiveness of it. And the discussion covered a number of different angles. One that emerged very quickly was the concept of building trust and the relationship between payers and providers, and that through participation in data aggregation and the right connection with practices, that actually this is one avenue to help build trust and relationships. And there was actually a discussion about how to best do that, really much more of a question than answer about the importance of that. There was also some discussion about, really, I think it boils down to the role versus claims versus clinical data, or for other data types. It jumped right into, well, claims isn't as timely as clinical, and you need timely data, and even a 3-month lag can be a challenge for the use of claims data. And that led to some discussion about the concepts of what's the right use for the different data types. So where clinical data and ADT notifications may be most valuable for in-the-moment care management, claims data may give more complete longitudinal information of certain kinds around people's patterns and needs, or around populations' patterns and needs, or certainly around performance. And maybe it's a combination of these two put together the right way that is most useful. And we just discussed potentially some examples of that, of how clinical data and notifications could provide links to claims patterns that gave more information about the person and the people involved. And so that discussion went on, but timeliness and maybe the different roles around care management versus performance emerged. We did then lead into a discussion about combinations of data types, and I guess if we're going to hold quotes here, I think Pano came out with, well, that would be the holy grail around the combined use of claims and clinical data, and we morphed into other areas such as social determinants and potentially other types of data. And we talked about some ways in which those could be used in conjunction with each other, and certainly enhance their utility. And I think that's an area that is, at least I see, really emerging around the country. That led to a little bit more focus on a discussion about social determinants data and the need for standardized codes, and how to go beyond Z codes, and then the Gravity Project, which is working hard nationally on putting standards and standardization to social determinants data. And that's something that will be very helpful in terms of incorporating it. But we also in that talked about a couple of examples about social determinants data, ways in which it can maybe be collected or used. Certainly the point of care, such as the Oklahoma example, where the HIE is helping to quickly activate collection of important social determinants data right at the encounter and make it available to use, versus other tools that are emerging, platforms such as Aunt Bertha was mentioned, these social determinants platforms where they can be linked right with the EHR or the HIE, and when you're working with a person, do assessments and quickly get connected with the resources in the community that people need to address those questions. And again, that seems to be an important data need that people are seeing, some emerging progress on. And then just toward the end, and I wish we'd had more time on this because it's a real important one, the concept about understanding variation and understanding variation in performance, understanding variation in quality and practice patterns, and how important data aggregation and the work with data aggregation is to really understand variation and then use that understanding, I believe, is where the conversation was going to guide ongoing improvement. So I would say at least one highlight that emerged for data aggregation is the opportunity for looking at and understanding variation and using that to drive our quality initiatives and model performance. So let me stop there and see if there are others in the group that were in the conversation and things that I may have left out.
It's Pano from Rhode Island. I think you did a great reflection or, summary. I just wanted to reflect on, I can't remember one of the colleagues, whether it was Bill or someone was talking about the difference when you had in practice facilitators, maybe it was Ken Rogers, about actually getting into the practices and working with them. And I don't know that how we know, we know that, but certainly that's been one of the elements we think is really successful. When you say, why do some practices perform better? Clearly physicians for sure don't get trained in how to do change management and how to be leaders. And, I think that the practice facilitation is a key component to a lot of this. And we think that when you give the tools and then they're in systems of care and then they're going to be PCMH, there's a lot of variation in what that means. And so I just reflect that as I hear some of the colleagues talking about what works and what they've seen in variation.
It also depends on the maturity of your program. So, when we first started, we've had PCMH programs now in our state since like 13, 14. And in the beginning, those in-patient, in-practice facilitators were critical. But then over time, it became more of a collaborative effort, more of a community effort. So, some practices still have care managers and coaching, but it's, I think it evolves once you get over a certain infrastructure and a certain culture transformation.
We said, and for example, when we did integrated behavioral health in a big way, and we've really expanded that, we use practice facilitators to bring, even the experienced practices. So I think you're right. It's not like you need it all the time, but when you're introducing a new innovation, I think you don't want to just say, oh, well, they did PCMH. They had practice facilitators 3 years ago. They're fine. We found that having an IBH practice facilitator made a big difference. And I can imagine if you start thinking about integrating social needs and trying to build community clinical linkages, that you may end up where that's an added value again. So just,
Yeah,
Great observation.
The difference between, it's like an airplane. There's a period when you're in the takeoff, which is different than once you get to a certain altitude.
The ever on ramp. So we do have one more little body of work to do this afternoon. I just want to hand the speaker over to David Kendrick for a quick question that he wanted to ask. Maybe he's not here. David, you on? All right. Well, another time. So I wanted to turn our attention to the survey that we fielded earlier this year. It was obviously the purpose of that was to understand what decisions of our various payer organizations who are participating in the CPC Plus were putting into place to support primary care. I don't think there was any question about the dire straits the practices found themselves in with the sudden elimination essentially of in-person visits other than for emergencies, and even then not necessarily being able to see their patients, and the obviously catastrophic loss. Oh, I had muted David, sorry. I'm just going to see if I can get him out of here. Okay. David, are you able to talk now?
Oh, that's great. My goodness, don't tell others about that power. I'll never get the word in edgewise.
I know.
Wow. So I just wanted to get everyone's advice on something that I hope doesn't take us off track from where we want to go. But I'm, as you know, kind of on the infrastructure end of all this work is where my heart is, and I spend my time getting data connected and working with data and trying to make it available in ways that are useful to achieve these transformations. There's this moment in time happening right now, and Lisa will remember me asking her advice on this in the past, and that is the federal government has this 90-10 program focused on the last of the high-tech dollars from the stimulus legislation back in 2008, and the last of these dollars are being focused around health information exchange and interoperability. And the work that my group does, that Ann's group does, that Dick's group does, is intended to be funded by those monies. Unfortunately, it all comes through individual state Medicaid agencies, and so there's no national level effort to tie us all together. And as you know, some percent of care crosses state lines, and there's a dramatic need, I think, for ADT alerting or alerting no matter where a patient gets care, so that the primary care doctor can be alerted for that. And the piece of infrastructure that accomplishes that is called the Patient-Centered Data Home. We were successful in getting Alabama Medicaid to include funding to make a national version of the Patient-Centered Data Home where we could all connect the HIEs with each other so that payers and providers and others could benefit from a nationwide picture of these alerts. But Alabama Medicaid correctly surmised, I think, that their local taxpayers didn't want to foot the bill for a nationwide network. And so we've been looking for a 10% match from a nonprofit or from some entity that's a valid contributor to the money so that we could actually roll out the nationwide model. What's been approved is something around $5 million, which means about $500,000 in matching funds to take all of it would need to be identified, but any amount would be helpful. What I'm struggling with is when I bring this to Gates, to Balmer Foundation, to these other foundations, they don't really have a frame of reference or a stake in the game. And I need some advice on where to go to find that. The window closes on this funding in September of 2021, meaning the nationwide network won't get built to do this.
David,
if we don't find this
foundation?
I haven't been to Arnold, no.
That would be something to
Is
look
that a place we should try? Okay.
I think they're based out of
Foundation,
Houston.
you haven't checked them out, David? Moore Foundation?
Who's that?
The Moore Foundation?
Oh, Gordon and Betty Moore?
Yep.
I could use introductions to these. I've used the ones I know, unfortunately. Okay. Even a local philanthropist would cover this base, but...
we can help, David.
Yeah, David.
It's Chris Kohler. We can help with Arnold.
Okay, great.
Erica knows a guy.
Okay.
I know a gal.
That'd be awesome. Okay, I'm sorry if I took us too off track, but no, go ahead.
Oh. This is all part of the same process. And if anybody has further suggestions and you don't know how to reach David, just send it to me and I'll forward that on.
Please
hey, David,
thank you.
Oh, sorry, just really quick. This is outside the realm of usual suspects, but organizations like the Kraft Foundation, I don't have any contacts for you, but they invest in all kinds of community health and community improvement initiatives. And they don't usually fall on the radar in this particular sector, but that may be somewhere to look as well.
Okay. All right. I sure appreciate it. Thank you, guys.
Sure. Okay, great. So just want to quickly turn back. We have just about 20 minutes. What I wanted to do was to ask you a series of questions, and we're going to use the polling functionality to get some sense of what your opinions were about the survey, the things that you may have found valuable. And then also I would like some advice as we try to figure out if we should do the survey again, if we do, how often, and what types of information would be helpful to you moving forward. So just as a quick reminder, the survey that we administered, I think it was in April, was asking specifically for your payer organization, and we had 40 responses out of the 60 payers that were contacted about this, so we're really delighted with that level of engagement. What actual activities in terms of supporting the practices were you involved in? And asking questions ranging from telehealth to accelerated payments, and then things that were not necessarily actually payments to practices, but other types of support that are non-medical, non-claims based, et cetera. And certainly for how long that type of support was going to be available, and then what plans were for the future. So there are quite a few questions that were part of the survey. You've all received a copy of the summary. I want to once again reiterate that our commitment to keeping all of the responses anonymous remains. We understand that this is potentially proprietary information that should not see the light of day unless you absolutely want it to. So, so we are completely committed to keeping this information de-identified. So with that, Erica, maybe I can probably just launch the poll from here, right? Looks like I can. Okay. So there's a series of questions, and if you just sort of scroll through them, you can see what maybe the useful insights you had. Should we do another poll? How often? And then some of the other questions. We'll give you guys about 5 minutes to just look at this.
Hey, Lisa, can you hear me?
Yes.
So something that we're playing with, and I think other Medicaid programs are playing with, I think it's going to be a hot topic, is what is the future of telehealth? Is it a silo? Is it an integrated? How do you integrate it? I think that's something that would be great to add into your agenda. So I think everyone's looking for a strategy and for, if you will, an effective use of the new technologies.
Thank you. Yeah, you'll see. So for question 4, I came up with these couple of answers, obviously, and Bill just gave us yet another option. So speak up if you have those in your mind now. We'd love to hear about it. So we've got about half the folks on the phone. I realize quite a few of us are staff, so probably not voting right now. Anyone still mulling over questions, or we can probably close the poll in a minute and discuss. Okay, so I'm going to end the poll now. Speak up if not. No? Okay, great. So can you guys see the results? Is that visible? Okay, great. So it looked like for those who answered the survey that about half, close to half for each of these options, either getting ideas from other payers or identifying barriers or learning about practice capacity to respond to the stressors. Those all sort of got close to the same amount of response. Looks like most of you, significant majority, would like to do another survey. Quarterly or semi-annually, it looked like would make real sense. And then this is the sort of the meat of the discussion. So one of the things that Chris and I have been really trying to understand is whether, and no one understands this yet, but we're going to put this out there. I think this is the group that would have the most insight into this, short of being able to talk to the practices themselves. But being part of the CPC Plus or some other program that has similar supports for practices, primary care practices, does that actually provide some sort of protection in terms of how the practice can respond to the truly devastating impacts of the pandemic? And that's not something that's going to go away anytime soon in terms of both the financial implications, but also certainly just the stress of taking care of patients in the environment where things are so uncertain, and just the ongoing human costs of practicing medicine during this time. And it's, there are ways of looking at this. We can certainly get the information from the payer side. I think all of you have been at least familiarized at least once or twice with the PCC survey that's being done by Rebecca Etz, looking at practices, responses to survey questions about how they're feeling and the resilience around that. We're trying to do some sort of a cross match around that to understand if the CPC Plus does provide that. But I just want to put that question out there, if that's something that would be, with these questions really aggregating to that, are we making a difference in terms of, this terrible stressor, if we can have our practices better prepared to deal with it. Chris, I don't know if I'm not sort of being a little inarticulate after 3 hours on Zoom, but if, that's a question we feel strongly we'd like to be able to answer.
I think the survey can cover or can answer at least 2 questions. One, Lisa, is what are the characteristics of more kind of COVID ready or COVID resilient practices, whether it's doing CPC Plus or something else? So how do you, to the extent you guys as experts can assess COVID readiness, a simple one is percentage of visits now versus before. So who's able to maintain operations? what kinds of practices are better suited to do it, and test the hypothesis that CPC Plus might make a difference. The other, and Lisa and I have been talking about this, is I'd be curious if people have concerns about free rider problems in your markets, that practices that step up to support primary care are subsidizing, I'm sorry, payers are subsidizing payers that don't. Obviously, this is less of a concern in a payer dominant market, but in a multi-payer market, should we be, and not so much CPC Plus, I'm actually concerned more about the markets that aren't CPC Plus. How do we maintain support for payers and pressure, frankly, for payers to continue to support primary care to be COVID ready and COVID resilient? My take is that we're going to have this for a while, and we need payer policies that support primary care. So do you think we should be worrying much about free rider problems and kind of creating an environment where payers are really sort of encouraged to do this work, or are they going to rise to meet the primary care needs on their own? So those are the two things we thought we can get out of the surveys: understanding COVID resilient practices and identifying the key payer policies that can support primary care right now.
Chris, I think those are good insights to get from the survey. One thing that I've kind of wondered about, and going back to my United Healthcare days, it seems like the payers may have line of sight into what the appetite is in a particular state or market for participating in advanced payment. If we think that advanced payment, which we do, is a good resilience move for practices, it would be helpful to know what's the universe of practices and their readiness for advanced payment. So if that's something that when the contracting arm of the health plan goes out and talks to practices and so forth, do they have some type of data on, hey, in Ohio, we've got, you know, a lot of practices that are still back in fee-for-service, or even among the gamut of practices that are in CPC Plus, for example, what's the variation of, you know, willingness to take on a risk contract like primary care first? That would help, I think, with the focus of where we need to go with the practices.
And you think the payers might have some line of sight into assessing practice readiness to move into more prepayments?
Yeah, I'm asking, and maybe the payers can comment, but my recollection back at United Healthcare was there was some ability to do that.
No, in terms
Sounds like that may have a connection to addressing the free rider problem as well.
Yeah.
As the greater benefit reaps to those who are in more risk-based contracts.
You know, there's a long-term and a short-term approach here. And frankly, I think until the November elections come and go, a lot of things will be frozen. And the outcome of the election and what happens after that, or the Supreme Court case, I think will start shifting things around in terms of operational structure. And, you know, so one thing in the meantime that might be useful is to understand how PCMH and CPC Plus and those other things have created new capacities, which could be resilience or other things that got people through COVID. So it might be useful to look at that to understand, you know, the culture changes, the community practice changes, the sense of new skill sets that were developed, and build off of that. Because I think until we see the November results and the Supreme Court results, we're going to have a lot of perturbations in the system.
So this is the short term while we have this opportunity. So moving forward, thank you first of all for participating in this in the poll, and it's certainly given us some information that we can start to work on. I will be calling on several of you to help guide us as we go through the next iteration of this. So it looks like we've got the go ahead to move forward, and I'll be calling on some of you as advisors. I really appreciate that. So we have a grand total of 5 minutes left from our 3-hour meeting. I am going to take this opportunity to thank all of you, and first of all for being the 60+ guinea pigs in our experiment to see how well we can do a virtual seminar. And I feel very grateful for your participation, for sharing your experiences, sharing your skills. And you know, being such valuable colleagues to me, certainly, and to each other. And we'll be in touch with notes and slides as we can share them. And I think we'll plan on another seminar for later in this calendar year to do something similar moving forward. So thanks again to our wonderful presenters and facilitators, and for your support in working on this. Thank you.
Thanks for your hard work, folks.
Thank you.
Thank you all.
Good job. Thank you.
Good conference.
Bye.
Bye-bye.
Thank you.